Hey there, folks. Guess what time it is? It's 4 o'clock in the mountains, which means 6 o'clock on the East Coast, and it is time for Fertility with Fink and Friends. I am Fink, and you are friends. And here we are, like we are every Tuesday evening at this same time. My name is Dr. Randy Fink, and I am the clinical director of IVF services here at CNY Fertility in Colorado Springs. And every Tuesday at this time, we get together and talk about all those things that are most important to us, things about women's health, things about fertility. This is your safe space to be together with a really fantastic group of people, very supportive group of people, and people who have the answers for you to the questions you seek. How you doing this Tuesday? Hey, here's an important message. Next Tuesday, Fink and Friends will not be on the air. So we will not be live next week because instead of Fink and Friends, we will be Fink and Vacation. How about that? So I'll be out of town next week with the family and looking forward to getting a little bit getting away, but we'll certainly miss all my friends here from Fink and Friends. And so let me just say good afternoon. It's been a great week, and the weekend was good. It's heating up here in Colorado Springs. Hope everybody's having a chance to watch the Olympics. So Colorado Springs, if you don't know, is Olympic City, USA. It's really kind of cool to drive past these buildings and see, USA basketball, USA volleyball, USA gymnastics, see these places and the the home offices for all these things. But really fantastic job to watch all of our athletes competing and really just going the extra mile to wave that flag for us. Let's see who's here. A special hello to Zenaida in Miami. Thanks for being here. Yanni, nice to see you. Veronica, Amber Vince, always a pleasure. JM Dots, thanks for being here. And the compliments on the frames. Yes, indeed, you are right. Another nice set of frames. Hey to Staley, I'm glad you could be here as well. Ariel Eden, good to see you. Let's see. First up, Shay Dunn. Nice to have you here with me today. Maggie Cox. Jenny, you are number one. Jenny Thiegels. You were the first on my Instagram feed, which is right here. We've got Facebook so far. Looks like 15 people or so on Facebook. And the first to say hello, hey to Glenda. From Miami. Awesome. My old stomping ground. And that's where I'll be next week. And Mandy and Liz over here on the CNY Facebook side. Let's see. We also have LinkedIn here in the middle, but first was Nick Betez. Nick Betez, you are number one. Rosa, thanks for being here, Rosa. And let's see what else we've got. Morgan Lynn Hunt, Jazzy Poo, good to see you as always. Hey to Brandis, thank you for being with me this afternoon. Brandis Montez, our wonderful nurse practitioner here, who can also answer some questions for you over there on the Facebook, on the Instagram side. Hey to Taylor and Barbara and Alexandra. Nick Betez says, I have been following the embryo transfer protocol from the Vitamin Victory. I had my first embryo transfer yesterday. Should I continue to take all the vitamins or should I stop some? So usually I recommend for the evidence-based protocol on the supplements, and there are 5 supplements that we use for embryo transfer. There's your prenatal vitamin. There's vitamin D, vitamin E, CoQ10, and L-arginine. I say stay on those until you get your positive pregnancy test. Once you have that positive pregnancy test, usually I recommend all you really need at that point is your prenatal, and I do very strongly recommend fish oil or omega-3. Why is that? Why do we talk about fish oil? Well, fish oil in other circumstances is a natural anti-inflammatory. So that's a good thing. It can be very effective for doing things like, in the anti-aging world, for decreasing your inflammatory markers and for lowering your triglycerides. It's a very good thing for that. In pregnancy, we know that that type of chemical substance, which is what is known as a phospholipid. These phospholipids are the same thing that the brain is made from, and the same thing that the retina in the eye is made from in the back of your eye. So, very clear studies that there is an improvement in visual acuity scores of babies that are and moms who are of babies from moms who are supplemented with omega-3 and increase in cerebral function, or basically the ability to think. So, yep, it definitely does something. The thing I always tell people, and I think maybe you've heard me talk about this before, but if you're going to get some fish oil, get the kind that says that it's burpless or odorless, because it is literally oil that comes from a fish. And if it is, plain old sardine oil and you burp that up, I guarantee you that will be the last time that you want to take that fish oil capsule. So, you can go to Costco and get, fish oil in the 10-gallon drum, but it may not be and it may actually even be high quality fish oil, but it may not be something that is particularly palatable. So some of them are flavored with like a little natural, like lemon oil or sometimes peppermint oil, or have something in the coating that keeps them from dissolving in the stomach, but rather in the small intestine, so that they don't kind of get burped back, because that burp back, as they call it, is pretty unsavory. So you will want to avoid that. So yeah, stay on your prenatals basically until you get that positive pregnancy test. And Nick, our fingers are crossed for you, my friends. I also want to say a very special shout out and hello to Sharmila, who came to the office today. One of the kind of really neat things at CNY Fertility, most of our consultations are done over the telephone. And so we talk to people and we set up plans, and we kind of put our thought process to what's it going to take to kind of be able to get you pregnant, listen to the stories, kind of see what you've been through. And then when we actually have a chance to meet people face to face, it's really kind of like a very unique, it's a very unique experience for me. So Sharmila and her husband came here from North Carolina to meet with me today, and it was very special to meet you face to face. Thanks for being all the way here in Colorado. Let's see. Lindsay K. Anderson says, how many failed transfers would you recommend before doing an ERA? Would you recommend a laparoscopy over an ERA? Okay, well, so here's the thing. An ERA is an endometrial receptivity assay. And in general, we find that an ERA is really no longer thought to be a very useful test. Why is that? Well, I mean, it's hard to say why it is, but I'll tell you why I say it's not such a useful test. So basically, this was predicated on this idea that we have a narrow window during which we can implant a pregnancy. That it has to do with a very specific amount of progesterone in our bodies. And to some degree, that progesterone level, that's very true. And that progesterone level gets too high, an implantation will probably not take place. So sometimes folks come here, they want to do a fresh transfer, but their progesterone levels are too high, above a 1.5. And in that scenario, odds are it's probably not going to work. And people get upset and understood, but it's not something that we can really control. It's how your body responds to the medication. But the ERA was basically worked on this idea that 75% of us have the same implantation window, which means that 25% of us do not. And so if you've had several unsuccessful embryo transfers and you weren't getting pregnant, part of what we would normally do is the workup would be to do an endometrial receptivity assay so that we could see when your precise implantation window is. Are you in the 75% or are you in the 25%? Because the 75% means that you're getting 120 hours of progesterone plus or minus 3. That sounds very precise, and it is. So that's why if you're doing a medicated cycle embryo transfer, frozen embryo transfer, we know exactly how much progesterone we can, say pretty precisely when you're going to do your embryo transfer. That's why we schedule it at a particular time. There is some specifics about how much progesterone you're getting. But that implies that 25% of people are outside that window. And indeed, if we do the test, which is an endometrial biopsy, it's a little straw that goes inside the uterine cavity and sucks out a little piece of tissue, and they can test for your implantation window. All that sounds, brilliant, right? It sounds really impressive science. And gosh, yeah, that must make some kind of a difference. Well, in fact, when they study that, what they find is that no, it really actually doesn't make a difference in the pregnancy rates. So you can do it and find that your number is 140 hours instead of 120 hours. But at the end of the day, um, you're not any more likely to get pregnant by doing that. Now, all of us in this fertility business have some patients that we've done an ERA on, had never gotten pregnant. We finally did an ERA. We adjusted the progesterone timing, and lo and behold, they got pregnant. But when they look at this, looking at tens of thousands of cycles, they found that the pregnancy rate using an ERA is no different than in folks who didn't test at all. And that's even in people who have had recurrent implantation failure. So an ERA is really not something, Lindsay, that I recommend anymore. There may be some isolated times when I say it sounds like a good idea, but in general, I would say save the money because it's not covered by insurance and it's an expensive test. And if it's not going to make a difference, I really don't want you to do it. It gives you some false hope. It costs a lot of money to do. Now, do I think that there is some tests that are beneficial? Yes, there are. And what you asked there, would you recommend a laparoscopy over an ERA? Well, so a laparoscopy is looking for something different than an ERA looks for. The ERA is specifically looking for the timing of embryo implantation. The laparoscopy is looking for endometriosis. Well, guess what? We can also test for endometriosis in a non invasive way, the same way that the ERA is performed. It's by doing an endometrial biopsy. And that test is called a receptiva. If you're not familiar with receptiva, I encourage you to take a look at it because it is a very good test and can save you from having to do a laparoscopy. I personally do not recommend laparoscopies for people for fertility reasons alone. The data is very clear on that. That now, if you have very severe, painful periods, and it sounds like you might have endometriosis, and we can make your periods better by resecting or by diagnosing by doing something with a laparoscope, then yeah, maybe it's worth it. But I do not recommend diagnostic laparoscopy for fertility reasons. I would say I think it makes much more sense to do a receptiva, especially if what we're looking for is silent endometriosis, Lindsay. And so it depends on how many transfers you've had. If you've had euploid embryos and two of them didn't work, then I would say it's time to start looking under some other stones and seeing what else is going on. Now, we know with a euploid embryo, one euploid embryo gives you a 65% probability of pregnancy. 65 is not 100, so it's certainly possible that one just didn't work. So then we would go and do another one. By the time you're on embryo number 2, that's euploid or chromosomally normal, you have an 88% probability of pregnancy. Okay, what if that one doesn't work? Well, by the time you're at embryo number 3, you're at a 95% probability of pregnancy. So certainly by the time that third embryo transfer is done and you haven't gotten pregnant, then I would say for sure we want to work that up. But for many people with a euploid embryo, I would say 2. If they are untested embryos, anywhere from 2 to 4 transfers that haven't worked, 3, 4, certainly I would for blastocysts if they are day 3 embryos. It's a different story because with a day 3 embryo, we're maximizing the odds that you're going to be able to get an embryo to put back inside of you. We just don't know whether that embryo, how that embryo is going to function. Is it going to work? Is it a normal embryo? Would it otherwise survive? So maybe a different story there with a day 3 embryo, but hopefully that answers your question, Lindsay, and all the best to you and yours. Molly Maroney says, I have my baseline today, start transfer meds tonight. Yay! Is it safe to book flights or is it smarter to wait? Okay, so you're talking about doing an embryo transfer. And since you're talking about starting meds, I presume that you are doing a medicated cycle. So when we do a medicated cycle for a frozen embryo transfer, we know that the only thing that needs to stay constant is that it's going to be 6.5 days or 120 hours of progesterone. The first part, the estrogen part, is what it takes to get the lining of the uterus thickened up like it does every month during a natural cycle. And that's typically 6 to 12 days of estrogen. So we can be variable with that estrogen. Now, if they started this whole thing for you and told you the likely date that you're going to be starting progesterone, the odds are pretty good that your body's going to respond the way it's supposed to. Might it change by a day or two? It could, but I think it's probably reasonably safe to say, hey, I'm going to go ahead and book my travel because I know when I'm going to need to be there within a day or so. So what's the worst case scenario? Well, maybe you stay here for an extra day. If you're trying to do it, get here that morning, do your transfer and leave that night. That's putting a lot of pressure on everything to work properly in terms of timing. And so I would be less inclined to do that. But if you've got a little bit of time to build into the schedule there just to make sure that everything works the way it's supposed to, I think it's probably fine to go ahead and book some travel if you're doing that medicated cycle. Now, the other alternative to a medicated cycle is a natural or a modified natural cycle. And that's really dependent upon when your body is going to ovulate, when your ovary is going to release an egg. And that can be a lot more variable. And I'm usually less comfortable telling people to go ahead and book travel then because, your body is going to do whatever it wants to do. And I think you got to be really careful about trying to make hard and fast plans when the body may have, may have a plan of its own. Okay, hey to Kristen. Thank you for being here. Cutie Camp says, going through a stim cycle and have been having rough headaches. Is Tylenol the best thing? Been hydrating and eating my best. So sometimes a little caffeine can help. Tylenol is fine and ibuprofen is okay as well. So the only thing is, so once you are pregnant, we typically don't use the non-steroidal anti-inflammatories like ibuprofen. You'll just kind of use Tylenol. But headaches are also kind of a big thing in pregnancy also, just because the progesterone levels start to get high. And that may also be, Cutie, what is contributing to some of your headache business there as well. Lichio, I can't see what that says, but George is the last part, says, what size follicles in order to trigger for retrieval? 16 or 17 is usually what I'm looking for in most cases. If you are planning to do an IUI, an insemination, then usually we trigger you at around 18. But for a retrieval, 16 or 17 is typically what I look for. Let's see who we have over here on my Facebook, on my Instagram here. I wanted to say, who else did I want to say? Oh, Veronica says, a well-deserved vacation. Thank you very much. My family, because we moved here to Colorado from South Florida, the family forgets what South Florida is like in the beginning of August. It's not really here in Colorado, it's dry. It's pretty cool most of the time. And by cool, it's cool relative to South Florida. But the kids wanted to go back, and so that's what That's what we're doing. Maria King says the first FET was unsuccessful. My progesterone was 21 at transfer, 17 at midway, and 12 at the beta. Is there anything you change to improve future FET chances? Okay, so that assuming Maria that you were doing a medicated cycle. So again, 5 supplements that I want you to be on for embryo transfer: prenatal, CoQ10, vitamin D, vitamin E, L-arginine. I wrote a little book on that, the Vitamin Victory. You can, it's through my link tree. You can see on my Instagram, Randy Fink MD. Click on that link. It's a $7 book, and it has a discount code that'll save you a bunch more than that if you want to buy any supplements from there. But at least then you have the list. So 5 supplements I recommend as part of the evidence-based protocol for embryo transfer. Your medicated cycle, we're looking for that progesterone number to stay around 20. Now, the truth there is that in nature, that progesterone level really just has to be above about a 2.5. So we're building a very large margin in there to make sure that you're getting enough progesterone. 17 is still pretty good. You know, it's close to the 20 that we're looking for. 12 is starting to get low. Now, that may also be because the pregnancy wasn't going to continue. And so that may have been a part of it there. But if in doubt, we would increase the progesterone in oil. Would we increase the vaginal progesterone? Well, when you're using progesterone vaginally, it really does not contribute to the serum levels of your progesterone. So you can do a blood test, see what your progesterone is, but the vaginal progesterone really just has a local effect. It's affecting the lining of the uterus, but not so much the progesterone that's circulating around in your blood. So what I would do in that scenario, Maria, is that I probably would increase the PIO dose. I would have a little, I'd have a lot of enthusiasm, little hesitancy is the word I was looking for, to just kind of increase that PIO. But is that why the transfer didn't work? Probably not, because still realistically, that's enough progesterone to keep a pregnancy likely ongoing. That's probably more likely an embryo issue, and I'm sorry you had to go through with that. But happy times ahead. How about that for sure? Another special hello to a beautiful couple sitting in Mobile, Alabama, and that is my mama and dada. The Bama gal and her handsome man. Thank you for being here on this Tuesday afternoon. You know, I don't get to see my folks very much, and so it's nice that now, technology being what it is, that they can just sort of tune in and see here. Have you talked to your parents today, by the way? Have you told your parents that you love them, that you miss them? If you haven't, pick up the phone and tell them, because they will appreciate it. And when you go to bed tonight, you will appreciate too, knowing that they know how you feel about them. Sharmila, thank you again for being here today. Mrs. E. Villarreal, where is reading those names from? Facebook? Not sure what you mean there. Oh, but because I don't know if you can see it or not, but I've got these names. I can see who's logged in, and when people ask a question, I can see that right here. So I try to get to all these questions, but then I get long-winded on things and try to answer everything, and then never get to them all. Okay, Melissa says, I have new IVF benefits. Is it worth it to even try? At 49 years, with ovulation induction at 49 years old, I trust your opinion. Would I be wasting money? I was successful with donor egg. So most practices would not allow you to do IVF at 49 years old. Why is that? Well, 2 issues there that plague us as we mature. And I prefer to think of it as maturing over aging, because I'm trying not to age, but I am definitely maturing. Some would argue otherwise, that all I'm doing is aging and I haven't matured since I was 14. However, I will go with the other choice. So, two things happen. One is, we're born with all the eggs that we'll ever have in the ovaries. And so over time, we start to lose those eggs. And that is why the AMH, the anti Mullerian hormone, that measurement of our ovarian reserve, starts to go down. And in fact, if you look at a graph of AMH associated with age, you'll see it's pretty precipitous drop as we get older. Um, well, the other thing that happens is that the DNA that's in those eggs becomes less stable. And so that's what I will call egg quality. We start to lose our egg quality as we mature. And there can be some instances where people prematurely have a low ovarian reserve, and that's what we'll call diminished ovarian reserve, or people at any age can, for whatever reason, have issues with egg quality. So, at 49, it would be very, 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 very difficult for you to, one, be able to produce an egg, not impossible, but difficult, and two, almost impossible to produce a normal egg. That is an egg with normal chromosomes that would have the ability to to create a normal embryo that would be able to get you pregnant. So, the odds of that happening are a very, very tiny fraction of less than 1%. And so, I would say, most practices would tell you, well, if you use a donor egg, your uterus doesn't age in the same way that the ovaries do. And so if you want to use, if you were to use a donor egg, there's a very, very high probability we'd be able to get you pregnant. However, with your own egg, Melissa, it would be a very, very hard uphill climb that likely would not result in success. Now, there are some folks who feel like they want to do what we'll call a closure cycle, which is where, well, they want to see, maybe they're going to be the outlier. Maybe it is going to work in them. And so they'll do a cycle to sort of see what happens. And I say, absolutely, you can do that. What I wouldn't want you to do is to get involved with saying, okay, well, I'm going to do a cycle. And then when it doesn't work, then you want to talk to somebody and say, okay, well, what can you change? What can you change to make this work better? And then somebody says, well, let's tinker with the medicine a little bit. And so then they change that, and then you do it again, and it doesn't work. Or maybe you get one egg that makes a day 3 embryo that unfortunately will not likely implant. And you say, okay, well, what can you change again? And before you know it, you're doing cycle after cycle after cycle for something that probably is not going to be successful. That's the sort of situation where we say, well, maybe think about other options. Can you try? 100% you can try. And at CNY, we are all about letting everyone who wants to try be able to do so. Hey to Amanda Jam. Dots says, I have another FET booked for this Friday. One of my new meds has left me far more prone to sunburn. Okay, yeah, I'm pretty crispy despite SPF 60. Is this detrimental to the FET? So, there are a couple of meds that increase your photosensitivity. One of those medications we use is doxycycline. Doxycycline is an antibiotic that you take for a few days because we're trying to decrease the colony count of the bacteria in the vagina, because we know that we're going to be taking a little catheter and placing it through that vagina into the uterus. And so, the uterus inside should be a sterile environment. So we might, we worry about seeding that environment with some bacteria. So that's the reason behind doxycycline. And doxycycline definitely can cause photosensitivity. It can make you feel hotter when you're outside, and it can give you kind of what they call sun poisoning, or it can give you a rash, or it can make you much more prone to a sunburn than you would otherwise be. Now, as long as you don't get a very severe sunburn, that should not affect your embryo transfer. But sunburn in general is not a good thing. Talking to the palest guy, this side of the Mississippi, I have paid the price for all those sunburns as a kid. So yeah, it shouldn't affect you for the transfer, but yeah, be aware photosensitivity is a very real thing with certain medications. Is there a huge difference, Maggie Cox asked, between a day 5 and a day 6 euploid 3AA embryo? No, really, there's not. Now, you raise an important point because you talk about an embryo grade and you also talk about a euploid embryo. So you had an embryo that was grown to blast. It was graded, which means the embryologist looked at it under the microscope, came up with some identifying features that they're able to assign some points to, and thus gave it a grade. The grade of the embryo no longer matters once you know that embryo is euploid, because really the whole goal of grading an embryo was designed to see, well, if you've got a beautiful embryo, a highly graded embryo, then does it have a greater probability of being a chromosomally normal embryo? And the answer to that is no, it doesn't. It does not. And so anybody who has done PGT testing will know that they can get a whole group of embryos that may be sort of across the board, different embryo grades. Your highest grade embryo may have complex chromosomal abnormalities, while your poorest grade embryo may be the only one in the bunch that's chromosomally normal. Well, guess which one is going to have the highest probability of pregnancy? That highly graded aneuploid embryo has about a 5% chance of getting you pregnant, even though it's a 5AA. Whereas your poorly graded euploid embryo has a 65% chance of getting you pregnant. So grade doesn't matter once you know that that embryo is euploid. But day 5 and day 6 embryos typically perform about the same. So good news on those embryos there, Maggie. Amanda Marie says, why would metformin be recommended if I don't have PCOS or insulin resistance? Okay, well, so the reason for that is that metformin is helpful in two other circumstances. We use it really for egg quality, Amanda. I use it really routinely in folks who have an AMH level that is above a 3. If your AMH is greater than 3, then that means you are likely going to be creating eggs in a high estrogen environment. And that high estrogen environment is associated also with some insulin resistance. We all have some degree of insulin resistance. And so metformin is very helpful in decreasing the high estrogenicity of the environment where the eggs are made, and thus making better quality eggs. I also like to use metformin in folks with AMH of less than 1. Now, not every time. Sometimes we do. There may be reasons that we do and reasons that we don't. But certainly with a very low ovarian reserve, I like to use metformin as well, because in addressing that insulin resistance in the body, even if it's just a little bit, you can dramatically improve egg quality. Amanda, that was a great question. Thanks for asking that. Okay, let's see what we got over here on the Facebook side. Oh, we got a bunch of questions there. So let's see. Liz Fisher says, I had my first FET with you this past Wednesday, and today is 6-day post transfer of a day 5 embryo. Got a positive pregnancy test. My first beta is on Friday. What numbers are you looking for? Well, so usually that first beta is in the anywhere from the 20 to 50-ish kind of range. So when it's in the teens, we often say, well, okay, let's just make sure that that's not from an HCG booster if you're using that, or let's make sure that hormone level. We always want to know when we do that beta hormone level that the number's on the way up. So usually we'll repeat it again in 48 hours, and we like to see the number doubling. But Liz, that is great news. I'm so happy to hear that. Sierra Price says, "Hi, Mandy Mears. Can you please talk about priming to help synchronize follicles? What's the best way to do this without suppressing the ovaries and getting fewer follicles?" One quick thing here is it looks like Villa Corta Charlena says, "Hi, Dr. Kiltz. No, 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 I am not Kiltz. I am Fink. You are friends. Kiltz no Astaki. Dr. Kiltz is in Syracuse and owns this wonderful company, but I am Fink, not Kiltz. Okay, so let's see. Mandy, priming. So the way I like to do priming, and now I try to do it in there's sometimes there's reasons that I won't, but priming is often a really good idea. And what I like to do is I like to use 7 to 10 days of estrogen and progesterone. It used to be that I would want to prime people for like a month at a time, or sometimes even 3 months. This is an older way of doing things, but that's the situation where that prolonged medication may suppress the pituitary gland. It may sort of turn down both the ovary and the brain's ability to kind of respond to those hormones. So I think a shorter term priming, 7 to 10 days, does a couple of things. One, it helps to coordinate the growth of the follicles in the ovary, and that's what you're referring to as synchronizing the growth of the follicles. Secondly, it primes the brain and the ovary and tells them, because estrogen and progesterone are the language that the ovaries speak. So, on one hand, it increases some blood flow that's going to the ovaries, and that's always a good thing. It helps to carry some of those supplements that I feel very strongly about, maybe the growth hormone if you're on that, or even just regular old oxygenated blood going to those follicles helps with egg quality. But from the standpoint of how those follicles will grow, it tends to take them all. Think of it this way. Think of, if you've got a bunch of little toys on the table, and they're kind of maybe some marbles. Well, you've got little marbles, you've got bigger marbles. You want to kind of gather them all in. You want to kind of bunch them up and put them into one little pile. It just makes them a lot neater, and that's kind of what it does to the follicles. And then as that happens, it tends to make them want to grow a little bit more of the same size. It sort of reboots their growth mechanism, so that then once they start to get stimulated, they are more likely to grow together rather than grow separately. Does that make sense? Hopefully so. That was a good question, Mandy. Sandra says hello from the United Kingdom. Awesome, Sandra. Thanks so much for being here. Okay. Bill Cordes said, correction, Dr. Fink. All right. Thank you. Appreciate that. Denisha says, thank you, Dr. Fink, for my egg retrieval on Saturday. My pleasure. I'm so glad you did well. Ariel says, I had my CNY baby in April. Not to rush, but I do have remaining embryos. How long should I wait before trying again? So you might have heard me talk about that the only preventable risk factor for severe preterm birth is a short interconceptual interval. We don't want you to have another baby right away because it significantly increases your risk for preterm delivery, preterm labor and delivery. So generally, I say I don't like you to start that process before about 9 months. Some people will say 6 months. The ideal window between pregnancies, according to the data, is from 1 to 5 years. But I think 9 months is fine. Don't rush too much there. But congratulations on that April baby, Ariel. Looks like Leah says, how difficult is it to do a modified natural transfer after 60 days of Orilissa? A modified natural is recommended. You can absolutely do it. So, I am a big fan of a modified natural FET, which is where we're giving you some letrozole. So to make sure that you're going to form an egg, that follicle grows and it makes a good amount of hormone. It also has a positive effect on the uterine lining. Well, so why don't we do it every time? Some people don't ovulate as well. And certainly if you've been on 60 days of Orilissa, we have, that we call suppression for a reason. We're doing that for endometriosis, but we're turning down the sensitivity of the brain. So is it possible, the pituitary gland, is it possible that you may not respond as well or as quickly or as predictably with a modified natural? Yes, I think that's possible. In most cases now, I tell people, if you want to be, precise about it, just go ahead and do a medicated cycle. Now you have because then there's no guesswork involved with it at all. Because your TSH was affected, you've got a reason that maybe you want to do a modified natural. Well, worst case scenario, if you're not responding the way you're supposed to, now you take a break. By the next month, you'll respond the way you're supposed to. So it's not that difficult. I think you can definitely do it. Lucretia says, is it absolutely necessary to take supplements and do carnivore for 3 months before IVF? I have a low AMH and diminished ovarian reserve. Well, so the evidence, Lucretia, is very clear that using the supplement, there is an evidence-based supplement protocol for diminished ovarian reserve that absolutely, has been shown to make a difference. Does it make a difference in every single person? No, it doesn't. Dr. Kiltz believes very strongly in carnivore, and he can speak to that probably much more readily than I can. We do feel like keto is an important thing: high fat, modified protein, and low carb. Keto carnivore is an extension of that. And I would encourage you to talk to Dr. Kiltz about where he sees the miracles of carnivore. I feel very strongly about supplements. And I certainly, the one thing that we all can agree on diet-wise is that low carb, minimizing your carb intakes. Carbs are pro-inflammatory, and inflammation hurts us. And so, to that degree, I think that really does make a lot of sense. MPG says, excellent service. I attest and testify. Okay, thank you. Taylor says, Taylor Ewell, my transfer on 7/18 was unsuccessful, but we're coming back. Is there something I can do to increase my chances? Also, can I do 2 embryos with a bicornuate uterus? So, I think the question about what else can you do to increase your chances makes, is a very individualized thing, and Taylor, and honestly depends on a lot of what's going on with you. And I don't have access to your chart right here, so I can't say for sure. 2 embryos with a bicornuate uterus. And it may be that transferring 2 may improve your odds of getting pregnant, since the first one didn't work. I do not generally recommend people transfer 2 embryos outside of guidelines with the first transfer. The problem with a bicornuate uterus. So what does that mean? Bicornuate. Bi means two cornuas, 2 horns. And so that means that the uterus is kind of shaped like a little Valentine's heart. It's kind of shaped like that. And so look, it made little hearts on there. How cool. That I love that. That was awesome. There, I did it again. It's not doing it on this one. It's only doing it on my Instagram. But so here's the heart. Here's a bicornuate uterus. So that means that a pregnancy can go up here, or a pregnancy can go over here. Bicornuate uterus can be associated with and is a risk factor for preterm labor. Having twins is a very significant risk factor for preterm labor, and we really don't want you to have preterm labor. That's one of the reasons that we, as an industry, are not. We don't want you. We want you to have one healthy baby at a time, because having multiples really does increase the danger to the pregnancy, danger to the babies. And so we really don't want that to happen. And because multiples would be already a pretty significant risk for for preterm labor, putting in two may also increase that risk for you. So I think it's definitely worth having a discussion about the risks and benefits there for sure. It's Claire Yufu. It's Claire Yufu. Do you have to wait between a live birth and a next transfer? And yep, I think we just talked about that. I like it to be probably about 9 months. I think is pretty good. Some people will say 6. If you had a C-section, some people will say wait a year. Ashley VZ, I have some hemorrhagic cysts in my ovaries after an egg retrieval 2 weeks ago. Can I still proceed with an FET? Yes, you can. So a hemorrhagic cyst means that, okay, when we do an egg retrieval, we place a needle into the ovary and we suck the juice out. And inside that juice is an egg, right? Well, your ovary hates empty spaces. And so what's it going to do? It's going to fill that space with blood. That's a hemorrhagic cyst. Now, even under normal circumstances, when you release an egg, when you ovulate, a lot of times that ovary will fill back up with blood. And a lot of people end up getting pain from that kind of cyst. And so they end up going to the emergency room. They get a CAT scan or maybe an ultrasound, and they say, oh, you've got a cyst in your ovary. And forever you think that you have some terrible diagnosis. You're an ovarian cyst person. Every woman who ovulates will have a cyst in the ovary every single month. So that's a normal physiologic functioning part of the ovary and doesn't mean that anything is wrong. But after your egg retrieval, yep, that space fills up with blood. It's a bruise inside the ovary. And what happens to a bruise turns a bunch of colors, and eventually your body reabsorbs it. It goes away. That hemorrhagic cyst left over from your egg retrieval should not have any effect on your embryo transfer. All right, so good deal there. Lycy over them, it looks like that says, how many monitoring appointments typically do you have before you get transfer date? So usually you'll do your baseline appointment. Usually you'll do a second one about a week later to see if you're doing a natural cycle, to see that you're forming a follicle. There may be another visit or two after that to see how that follicle is growing. Otherwise, if that's your progesterone start visit, if that lining is thick enough, then your transfer is scheduled at that point. Let's see. Veronica Sanjar says, I'm new to CNY after 3 chemical pregnancies with 2 fresh transfers and 4 euploid failed transfers. I have no embryos left. I'm 40. My tubes are removed due to hydrosalpinx. No sign of endometriosis. Hashimoto's. Recommendations for next steps. Well, it sounds like there you are going to have to do another egg retrieval. If you have no embryos left, we're going to have to make some more embryos. And so, at 40, I kind of feel like, especially, gosh, you had 4 euploid embryos. I'd want to throw the book at you, throw the kitchen sink at you to do everything we can to really maximize your egg quality. So that may be, that's going to be all the supplements. That's going to be some growth hormone. That's going to be pay attention to your diet. That's going to be some metformin. I'm going to do a little bit of priming, and we're really going to maximize the dose of medication that we use for your stimulation. Okay, well, what happens then? You probably, Veronica, from the sounds of it, meet the criteria for what we know of as recurrent implantation failure. You had those biochemical pregnancies and 4 euploids, and by 4 euploids, you have, an extremely, 3 euploids gives you a 95% chance of a pregnancy. So if you had 4 euploids that didn't work, something else is going on. If it's not endometriosis, and I would say Receptiva is a very good test for that. You say no sign of endometriosis. So I don't know if you had a laparoscopy where they looked for it. I would certainly test for endometriosis, but that's what the medication Prograf is for, or tacrolimus. And the studies show us tacrolimus at 3 milligrams per day that's either 1.5 milligrams twice a day or 1 milligram 3 times a day, can very dramatically improve the pregnancy rates. And I typically use it really for everybody having an embryo transfer, because if we haven't gotten to the point where you failed a bunch of transfers, let's not get you there. Let's see if we can get the body not to reject the pregnancy. So between those 4 euploids and the 3 biochemical pregnancies, I would absolutely want you to be on tacrolimus for your next embryo transfer, especially if you've got a euploid embryo. Now, I wouldn't wait to do receptiva or anything else. The clock is ticking on those ovaries. So the sooner we get eggs, the better off we're going to be. The younger we are, even if it's by a month or 2 or 3 or 4, but especially by age 40, small differences can make a big difference in terms of timing. The quicker we get those eggs from you, the greater the probability we're going to be able to get nice normal eggs to make nice normal embryos. So that's my thought there. Let's see what else here. Nurtured Shanna says, I've been taking Provera and estrase to prime before starting my stims next week. I got my period today. If I continue to take the meds, are we still on track to start stims? Yeah, so sometimes what happens, I usually like to start that priming like on cycle day 21. So it's in the luteal phase of your cycle before you start doing your stims. And sometimes what'll happen, because you already ovulated, you may break through and you may get a period. And that period doesn't have anything to do with what we're doing here. As long as we're not kind of trying to plan to do a medicated, or rather a fresh transfer, then it doesn't matter at all. And yes, 100% Shanna, you are on track to start your stims. Don't worry about the bleeding. Okay, let's see. Brittany Lynn says, just had a hysteroscopy and a laparoscopy and ended up conceiving that same cycle, but found out it's a chemical and my progesterone is low. Is this common? And what should I do next? Well, yeah, so sometimes what happens, particularly, after the hysteroscopy, or depending on what they did with the laparoscopy, the hysteroscopy can sort of wash out some of the debris that's in the fallopian tubes. The laparoscopy may have helped to remove something that was creating an inflammatory effect. And lo and behold, people get pregnant there. I'm so sorry that you got that chemical pregnancy. That's very, very frustrating, especially, sort of after what you've been through. An unhealthy pregnancy will typically have a low progesterone. So it doesn't mean that a low progesterone caused the pregnancy to be unsuccessful. Typically, an unhealthy pregnancy has a low progesterone. So next step is to proceed forward, Brittany, with your treatment there, because at least what that tells me, we're a half a step in the right direction. That means the brain's talking, the uterus is listening. You were able to implant a pregnancy, but there was something about that pregnancy that prevented it from growing. So I feel very optimistic for you that there will be happier times ahead. Yes, indeed. Can chronic endometritis be treated with antibiotics completely before transfer? This is from Rosa. How can I make sure I clear that endometritis before the transfer? Yes. So endometritis is a chronic inflammation in the uterine lining, or in the endometrium. We treat that with doxycycline typically, and it's usually 100 milligrams twice a day for 14 days. You can treat it with, you can use Zithromax or azithromycin. You can use erythromycin. You can use Cipro, although we don't typically recommend that class of drugs anymore if we can avoid it, because it can cause some other problems in the body. But yes, so chronic endometritis is considered treatable, even though some people are just kind of chronically inflamed. The treatment recommendation is that doxycycline, and there is no recommendation that we need to test it again before you do embryo transfer. The treatment alone is considered therapeutic, and so then you ought to be able to put it behind you and move forward. Tina says a DNC after a miscarriage on June the 5th. I'm so sorry, Tina, to hear that. The HCG was as low as 2 on 6/26. No menstrual cycle yet, but hoping to see it soon. can I schedule a hysteroscopy? Should my menstrual cycle return soon? Yes, it should. So some people, after having a miscarriage, will then end up having a spontaneous period. If you had a DNC, then that means that your OBGYN cleaned out a lot of that uterine lining. And so there may not be a lot to slough off. And so what happens in that scenario is that the pregnancy hormone, the beta, drops down to negative. And then that lining is going to start to grow because it's almost like that was the period, even though you didn't have a period. That lining will start to grow. 14 days or so later, you're going to ovulate. And 2 weeks after that ovulation, you're going to get another period. So, yes, your period will indeed come back. Do you recommend getting any more testing before an FET after having a salpingectomy, laparoscopy, and hysteroscopy? I think you covered the bases there, my friend. They got some tissue with that hysteroscopy. Laparoscopy looked for endometriosis. Salpingectomy, you took out those tubes that may have been inflamed. So my guess is that you are probably ready to go. Let's see here. We got some other questions. Gosh, boy, time is really flying. We got about 5 more minutes here on Fink and Friends. Thanks to everybody for being here this Tuesday afternoon. Do you recommend, this comes from Sparkles, low-dose naltrexone for someone prepping for an FET with ulcerative colitis? And for how long? I'm on Stelara every 4 weeks. I know folks on low-dose naltrexone actually, it's considered an anti-inflammatory, and so it may have a very positive effect on the ulcerative colitis. I'm not familiar enough with Stelara anymore, so how those things might interact, I can't say for certain, but I wouldn't have any problem in general with ulcerative colitis and low-dose naltrexone because that is actually one off-label potential way to help the chronic inflammation associated with UC. So, yeah. Let's see, back over to the Facebook, YouTube, and LinkedIn side. Do I recommend PRP? So there's 2 different ways that we can do PRP. We can do intrauterine PRP, which is really kind of the most healing salve we can put on the lining of the uterus. So yeah, that's a good thing. And intraovarian PRP helps potentially with egg quality and those with a diminished ovarian reserve. Many people in our company believe in doing what's called a high dose intrauterine PRP, which is where that PRP goes in, treats the lining of the uterus, and is expected to wash through the fallopian tubes and to land on the ovaries. That's not something I advocate, but many in our company do. So do I believe in PRP? Yes, I do. It's still considered experimental. We don't know the ideal circumstances for who's the best candidate, when to use it, at what kind of intervals. Those things are being studied, but yeah, if you can do PRP, if there's a place for PRP in your protocol, I'd say, yeah, I would. Ashley says, when should someone do lipids and an HCG wash? So I recommend, so the intralipid is an IV infusion. It's really like an IV infusion of a keto diet. It's an infusion of fat that is a very potent natural anti-inflammatory. I think really, if you're able to, everybody should be doing a lipid infusion. Do you need to do that lipid infusion every single week? Not necessarily, but if you can, I think it probably does make some difference. The HCG wash I also recommend really for everybody because why not? It's not expensive. You're putting pregnancy hormone in that lining of the uterus, which takes the volume knob for some of those implantation type proteins and the things that our body makes to try to receive a pregnancy, and we're cranking that volume knob up. They can be done at the same time, usually a day or 2 before your embryo transfer. It just requires typically that you be here in one of our clinics because those 2 things are kind of hard to get done outside of CNY. Well, you have to have an infusion center, and that gets a little bit harder, and to have somebody who's comfortable doing an HCG wash may also be a little harder thing to find. And let's see what else. Caitlin says, can you still do IVF without the supplement NAC? NAC is N-acetylcysteine. Yes, absolutely. Absolutely, you can. So there's some people who don't believe in those supplements at all. And so, maybe just be on a prenatal. I happen to think, the most important one really from the supplement list, if you're going to take nothing else, take a prenatal and take CoQ10. CoQ10 is very important, either 400 milligrams if it's in the ubiquinone form or the ubiquinol form, 600 milligrams in the ubiquinone form. And that's probably the most important thing. Now, the other ones also really show NAC is one of those, but can you do IVF without it? 100% you can. Pretty much lots of the stuff that we do in IVF here, you can decide whether you want to participate in or not. Maybe you don't want to do something in the immune protocol, and that's purely up to you. We make our recommendations, and it's up to you to decide which of those you want to embrace. I think one more question. I lost sound. So, well, gosh, I hope the sound is still on because otherwise, yeah, there's still 29 people over there. So somebody must be listening. Sama says, who with an AMH of 0.01 and FSH of 38 managed to get pregnant. Well, that is really wonderful. That is quite, and that's a miracle. So, gosh, on that note, I think we have to stop right there. It is so wonderful to be with you guys every single week here. Remember, no Fink and Friends next week because of Fink and vacation. I wish I could take you all with me. If you'd like to come, I'd welcome you. That would be great. We can have a good time together. I have a good time here every Tuesday. So how about 2 weeks, 4 o'clock Mountain Time, 6 o'clock on the East Coast? We'll be back together for Fertility with Fink and Friends. Every step forward with kindness, every act of kindness you do on this world shows that the world is a place that we can all change one step at a time. Please lead forward with love and especially with hope, knowing that tomorrow is a new day. The sun rises again, and all those bitter things that we left behind from yesterday are indeed behind us. And what we have to look forward to is that new day and tomorrow. This fertility thing is not the novel of your life. It is just a chapter. And what are we here to do? We're here to rewrite that together. So until we are back together again, live from Colorado Springs, I'm Dr. Randy Fink at CNY Fertility. Thanks for being here. Good night.